Hello everyone. Hi Dr. Lata.
Oh,
Good evening Dr. Rangila. How are you?
I'm fine, thank you.
I'm Dr. Archana Baser here. I spoke to you long back with like when your ultrasound some center was to be recognized for the Prachi and everything.
Yes, I remember you. And
Oh,
your ultrasound workshop, it was very successful, it was very nice, and we still remember him.
thank you so much. Thank you. Hi Dr. Jyoti. How are you? Jyoti
All
di?
good. Yeah, I can hear you.
Yes. So thank you so much for joining.
I'm meeting you for the first time, Dr. Jyoti.
Hello, doctor. How are you?
I'm fine. You are from?
Right now, I'm in Indore. Basically, I'm from Gwalior,
Oh, I see.
Madhya Pradesh. Yeah.
I'm from Muzaffarpur, Bihar.
Okay.
अभी बाहर जाओ, बाहर जाओ। ऑन सब लाइट ऑफ करो ना, लाइट ऑफ करो तो अच्छा से दिखाई देगा।
So, Dr. Sinha, are you with some medical college or were you with some medical
Yeah,
college?
I'm retired, madam.
No. So am I.
you you will not believe that I have retired at the age of 58 in 1998. Now guess what is my age now?
You look as young as anybody.
I was a professor and head of SK Medical College, Muzaffarpur,
Okay.
and from there I retired in 1998.
प्रणाम मैडम, मैं डॉक्टर मंजू सिन्हा गया से।
Manju Sinha, Gaya.
जी
Nice meeting you. Nice meeting you.
यस मैडम,
This is Corona gift for all of us
यस
that we are meeting so
ऑन द वेबिनार,
frequently.
यस या
प्रणाम मैडम, सबको प्रणाम।
हाँ, आशीर्वाद आशीर्वाद दोनों हाथ से आशीर्वाद दे रहे हैं तुमको। ये मेरी बहुत फेवरेट स्टूडेंट है, इसको हम ऑनर्स दिए थे। अभी तक लेकिन ऑनर्स का ये प्रूविंग हरसेल्फ।
अब दवाई क्यों नहीं लेके आते हैं मैडम? उस दिन भी हो रहे होंगे।
Good evening, madam.
सुस्मिता, हेलो सुस्मिता।
Yes, ma'am.
हाँ, you are from Ranchi.
Yes. Good evening, ma'am.
Good evening, good evening. Tina Gupta, from where you are? Unmute yourself.
Ma'am, Bhopal, Madhya Pradesh, Bhopal.
Oh, nice meeting you.
Yes, ma'am.
And
Same here. We need your blessings.
Bajwala Tiwari. Bajwala
Ma'am,
Tiwari.
I'm from Indore.
Oh, Indore conference, I remember long back. Recently,
Yes, ma'am.
when was the conference in Indore? Recently?
2022.
Madam,
2022 we did.
COVID time.
22. That time I didn't go. Actually, it was sometimes postponed, then again it
Yes, madam.
lots of
Ma'am,
confusion was there.
yes, madam. Probably you attended ISOPAB long back in Indore. That was ISOPAB conference.
नहीं, ऑल इंडिया कॉन्फ्रेंस लॉन्ग बैक दो बार हुआ है, बहुत पहले भी हुआ है एक बार। हमको लगता है
it was in around 75, 80s के टाइम पे।
हाँ, उसी समय हम ज्वाइन किए होंगे। हम अपने सभी लड़कियों के साथ, लड़के के साथ, पूरा फैमिली के साथ हम ज्वाइन किए थे। दैट वाज 1975, लॉन्ग बैक।
प्रणाम मैडम, रंगीला मैडम प्रणाम।
हाँ, खुश रहो।
Madam used to attend the Foxy conferences, I think, long time back with family.
कब से शुरू किया था कॉन्फ्रेंस, हमको तो अभी याद भी नहीं पड़ रहा है। 1968।
Good evening,
68.
Dr. Lakshmi.
Madam, Dr. Jangalwala sir was HOD Indore. Professor Jangalwala sir was HOD Indore Medical College. That time once it was organized all India.
हाँ हाँ, ऑल इंडिया बहुत पहले हुआ है, वो
मैडम,
बता रहा है 75। तुम ठीक ही बोल रही हो, 75 होगा, आई डोंट
Hi
रिमेम्बर।
Neha ji.
Hello.
Hello everyone. Hi,
Hello,
Niva.
Ashna. Hello,
Hi,
Ashna.
Niva.
Madam. Yeah.
So, shall we begin? Countdown. Where is our
I know.
Sushmita?
Yes.
So, we have to be on time.
Yes.
Hello, how are you? I spoke to you.
So
लता
we
जी कैसी हैं आप?
are starting with our webinar now. Sakshi, are you there?
Yes, ma'am.
Yes.
Good evening, everyone. Good
So,
evening.
start.
गर्मी लग रही है,
So,
नहीं, लेकिन है, गर्मी कैसे लग रही है?
would like to invite Sushmita Mukherjee, ma'am,
नहीं
for
आ
the
रहा है। अब आ रहा है, और नीचे करूँ, अब आ रहा है, हवा नहीं आ रही।
Sakshi, you are not visible.
one second, ma'am.
So in between, good evening to Lakshmi ma'am. I have been sending
Hello.
messages to you.
गुड इवनिंग। हाँ, लक्ष्मी, लक्ष्मी।
हाँ,
Yes.
आपको बहुत सारा मैं फोन और मैसेजेस करते रहती हूँ। नमस्ते, गुड इवनिंग।
Nice meeting all of you. So
Thank you,
nice.
madam. Yes.
I enjoy this time more than the webinar because that's
I
the
know.
time when you can connect with everyone who is joining in for the
So
webinar.
try to manage this early time, at least 5-10 minutes.
Yes, that's a
So let's
faculty's
start.
own time.
Yes.
Yes.
So, good evening, seniors. We'd like to start our webinar, and for that, I would like to invite Sushmita Mukherjee, ma'am. Ma'am is a life member at Foxy, ISAR and IMS, and she's interested in advanced laparoscopy, IVF, and high-risk pregnancy. Madam is also a national faculty at AICOG, IH, and ISAR, and she has received certain awards like IFS MP Chapter Award and Star Dronacharya Award.
That's all. That's all. Yes. So thank you, Sakshi. Sakshi is a very young, enthusiastic laparoscopic surgeon, and she's assistant professor in Sri Aurobindo Institute of Medical Science in Indore. And she's the MOC of this webinar. So thank you, Sakshi. So let us start with our well-awaited webinar series, Shrinkhala, and our coordinator, Dr. Archana Basir ma'am, the presidential candidate for 2026. She is the program director, and she's the brain behind and also the energy source for all of us, and a very versatile person, senior endoscopic surgeon, IVF specialist, and also deals with high-risk pregnancy. And may I have Madam's CV? So she is VP Foxy 2020, MP ISAR Chairperson 25 to 27, ISPAC Joint Secretary 25 to 27, Fellow Representative RCOG West Zone 25 to 28. She is the Guinness World Record holder and removed the largest uterine tumor. She has organized AICOG 2021 Indore, and she is chairperson Foxy Imaging Science Committee 2015 to 2017 and organizing secretary ISAR 2016 and managing committee member ISAR 2018 to 20. So I would like to invite Madam to welcome our guest of honor and chief guest, very senior faculties who have joined us, and extremely thankful to everyone who have joined this webinar. So welcome, ma'am.
you, Sushmita, for
इसमें
the
लगा
kind
रहता है तो
words.
ज्यादा अच्छा रहता है।
And thank
देख
you,
लें
Dr.
फोटो
Sakshi, for opening
कोई
up
लगा
the webinar. Can I ask Mr. Sudeep to start with the lamp lightning before we get on with our, because this is I think something which is a ritual which we should be fulfilling whenever we are going and learning something. So, is Mr. Sudeep, can we have a little lamp lightning thing? Yep. I think everything which begins with any Vandana is going to be a great learning and good for all of us. So, at the outset, let me welcome all the dignitaries and all the faculties who have joined us on our MP ISAR webinar along with Indore Obs-Gynae Society Specialist Association. And I'm really grateful to Dr. Sushmita, Dr. Sumitra Yadav, Dr. Brajbala, and Dr. Sunita Chauhan for really collaborating with the MP ISAR and coming up with such a beautiful webinar. And the topic of today's webinar is something which is like an everyday affair for gynecologists. And when I was talking to Sushmita, I said, we every day we get a lot of adrenaline rush as an obstetrician. So why not to have a panel, something on adrenaline rush in labor room? And she spoke to Prachi. So that's how we all got connected. So Prachi has been very instrumental in connecting all of us on this platform with all Bihar societies. And let me tell you, I mean, I have a very great, deep connect with Bihar because I'll say from here that my daughter is married in Bihar and my daughter-in-law is also from Bihar. So it's a really good connect, and I'm really happy.
नहीं सुन रहे नहीं सुनाई पड़ रहा है
Ma'am, you are muted, ma'am.
मेरा
I'm sorry, I got muted. So we have representation from all the societies, and I'm grateful to our guest of honor, Dr. Rangila Sinha, and our chief guest, Dr. Jyoti Bindal, for gracing the occasion. Can I have the CV of Dr. Rangila Sinha? Now, Dr. Rangila Sinha, I've known her for I think last 20 years, and I've been communicating her with her in on different platforms. She has been vice president of Foxy in 1992-93. That's a long back. She has been chairperson Public Awareness Committee, and she's founder president of Muzaffarpur Obs and Gynae Society, and she has written books, and she has many awards to her credit, and she has actually written a foreword for Professor Arul Kumran, past president FIGO. I think she's a teacher and she has taught so many of us and so many things to learn from Dr. Rangila Sinha. And especially when we talk about obstetrics, we still need senior obstetricians who can give us little tips and tricks about the problems which we face in the labor wards and in the maybe in the cesarean section or emergency rooms. So over to you, Dr. Rangila Sinha, to give us advice and blessings and your words of wisdom for this webinar, where this is giving us an opportunity to connect with all our colleagues from MP and Bihar and other parts of the country, those who have joined in. So over to you, Dr. Rangila.
Thank you very much. Am I audible?
Yes,
Am I audible?
Yes, ma'am. Yes, ma'am.
Thank you very much, Dr. Archana. And I have met you so many times, and I always appreciate you And I very much appreciate you that you have invited me in this webinar, and you have given me opportunity to meet so many people. Because these days, due to age factor, I am not visiting many places and not meeting people. So for me, this webinar is very important. I'm thankful to Dr. Susmita Mukherjee and all the organizers for inviting me and for arranging this webinar, where the people from Bihar and MP, they are meeting. I will say that you have chosen this topic at the right time, and it is very appropriate at this moment, this present moment, when I will say that this is era of cesarean section. I have practiced, I'm still practicing, not that much. I have practiced obstetrics for last more than 55 years. And I have practiced both in pre-cesarean. Means that was time when cesarean section was not accepted by people. The attendants were requesting that please try to give her vaginal delivery. Don't go for cesarean section. And now I am seeing this is a time that when I think that there is a need for cesarean section, the attendants are saying that because this my daughter and my daughter-in-law, she will not tolerate labor, kindly go ahead with cesarean. So I am seeing this situation. But we obstetricians are pendulum between these two extremities. So we have to keep our knowledge, our skill intact to tackle all these types of emergency for which this webinar you have organized. This webinar will deal with all the emergencies for which you are anticipating, although one should always anticipate for good, but should be prepared for the worst. So anticipating something which may happen, one has to be prepared. And that is situation in labor room emergency, that sometimes unexpected things happens at unexpected moment. And there you have to be prepared. This is time that, although I will say that instrumental delivery is declining, our art of obstetrics is losing ground. Both the patients and doctors, both are responsible for that. But still, we should try to focus our attention in sensitizing our young doctors, our residents, for the need for their development of their skill, that whenever it is required, they should not go straightforward for cesarean. Because if everything is turned into cesarean section, then where will be skill of obstetrics? Anybody will go for cesarean, even surgeons, and they are doing these days, do cesarean, and why patient will come to obstetrician? They will go instead to surgeons for delivering by cesarean section. So when it comes to our skill, preservation of skill, then it is always, I will say that it is need of the hour that our juniors should be sensitized and they should be prepared. They should get opportunity to watch and see that what can be done in these situations. Is there any alternative than cesarean in difficult situations? And how far it is safe to deliver by instrument? Because everything depends upon skill. That time also, the kill and forceps was so popular that Dr. one of the doctor, I'm forgetting the name, very old obstetrician. He used to say that give me a pair of Killian forceps and a low forceps and I will deliver or women. There was no need of cesarean section. So that expertise, it is very difficult to obtain. But still, we should have some our skill intact so that we will be different and we will practice as a different obstetrician, not as a surgeon who is doing cesarean section. So I advise, I appreciate all of you, and I'm looking forward myself, I'm looking forward that how persistent occipito-posterior is built in this stage and how the speaker will justify and put forward this example that it can be tackled from vaginal route. Not always, but in many cases. Also, instrumental delivery, although it is dying art of obstetrics, but still we have to revive it and as far as practicable, this art should be preserved and whenever it is safe, then we should always try, our juniors should always try, and we should always be taught. And because there are because we are doing cesarean, so they don't have opportunity to see. We have seen the skeleton forceps, difficult forceps, and all sorts of destructive operation also. And all sorts of difficult instrumental delivery. So instrumental delivery where always I have different types of experience, bad and good, both. But still I had opportunity, exposure. But these days, the juniors, they don't have exposure. So at least for their exposure in medical college, they should see that what else can be done except apart from cesarean section. So not everything should be done by cesarean. And patient during antenatal period, also patient should be advised and persuaded that don't go always for cesarean section. Cesarean section is not safe as you are thinking. So I wish this webinar, it will clear many doubts and the audience after in the end of this webinar will have some new idea and tips. And I wish all of you, all of you are junior to me. I have completed 87 years. But if you will keep your health and you will look after your health, that at 87 also, you can do some practice and you will keep yourself busy. So I bless all of you. ये मेरा दिख नहीं रहा है, दिखो ना. All of you that you should be more active than myself at my age. And I wish you all the blessings from my both hands to keep your good health and good spirit. Thank you very much.
Thank you, madam. Thank you very much for your kind words and thank you for your advice. I think it was the depth of the knowledge and so many years you have put in obstetrics that was coming out. And I think rather than taking the tips and tricks of how to deliver the baby, we as an obstetrician and gynecologist of this time want to take tips and tricks from you to how to stay fit at 87 and command the command words you have and the way you have spoken. I think it's phenomenal. So really bow to you for your fitness and for the the abundance of experience you have. And thank you so much for blessing us. So thank you, ma'am. Please stay with us. And at the end, if you can stay and give us further advices, that will be helpful. So now I would like to invite Dr. Jyoti Bindal. She is basically an elder sister to me. And Jyoti Bindal has been, she's always a person I can bank upon when I need advice or guidance, because she is, if you see her picture, ever smiling picture, and she's always ever smiling and ever helping person. She is Vice Chancellor at Sri Aurobindo University, Indore, and her major achievements are she has been honored with FRCOG by Royal College of Obstetrician and Gynecologists. She has a DJ Jolly Oration Award 2021, Foxy Shiromani Award, Foxy COVID Technical Advisory Committee. I think we have seen Dr. Jyoti Mindal working in COVID when she was the Dean of MGM Medical College during that time. And she has been, like the person who still keeps a diary, case diary of the difficult obstetric cases. And she's ready. When I ask Didi, Jyoti Di, can I just have something? She will immediately give you WhatsApp, or she'll give you a message, or she'll send you on the email whatever you need, ever ready. Case diaries, difficult situation. So Didi, thank you so much for your advices, and over to you for giving us, your words of wisdom, and bless us on this webinar and our efforts to connect with everyone, and our efforts to revive the art of instrumental delivery and delivering in difficult situation, and how to really handle the rush situations in labor.
Thank you so much, Archana. I feel very humbled and I'm so honored to be a part of your webinar. I'm so honored to be in presence of Dr. Sinha, who we all know as a legend. But more importantly, I'll just explain in a moment why I think today's topic is so apt for Archana. We have all felt it, that sudden rush of adrenaline in the labor room. 1 minute things are so smoothly progressing, and suddenly you're scanning the CTG, you're calling for help, you're repositioning the patient, you're preparing for an emergency. So it's kind of an intensity no simulation can ever replicate, because in real life, the stakes are visceral. The two lives, one movement, no room for error. And this is the space where experience meets instinct, where our protocols would guide us, but also our judgment will define us. And remember, for us obstetricians, labor room is just not the place where only babies are born, but where resilience is tested. Communication is everything, and calm under pressure becomes a clinical skill. And that's what I mean when I talk of Archana Baser as the person who remains calm in a storm. I have seen her, sorry to be so direct, but I've seen her personality versus other VPs who were from the same city, and you can make out that calm presence in presence of a storm. And that's how I think I can best explain Archana as the person who will go beyond our imaginations. Because when we explore the adrenaline rush in the labor room, we're not going to just reflect as to what we will do, but also how we will do. So when we talk of presidency for Archana, we're not going to see how she will do, but also what she will do. So this is what we are looking at: the rapid decision making, the interdisciplinary teamwork, the critical seconds, and very importantly, the silent strength behind every scream, every call, and every let's go for an emergency management. So this is the world Archana is going to step into: our chaotic, our high stake, our deeply human world, where also I'm sure many powerful stories of Foxy will emerge. Archana, we wish you all the best, and very, very happy to be a part of your team. Thank you so much.
What can I say, Dr. Jyoti Bandal, Jyoti Di, for you? I mean, immense confidence you have built in me, and the trust you have in me. I really appreciate it, and I'm really thankful that you have joined in and you have given your precious time to us, and you have what a beautiful description of today's webinar in terms of building strength, building skills, and adrenaline. So thank you very much, Didi, and if you can stay with us, that will be really nice, so that you can give your inputs on how we have really selected the topics, and all our panelists who are really going to put in their knowledge and their skills and the way they have dealt the different situations in the labor room. It will be nice to hear every one of them. So thank you very much, Jyoti Di. Thank you very much, Dr. Rangila Sinha. And over to you, Dr. Brejbala, for taking the scientific session further.
Good evening. Thank you. Thank you so much, both the eminent guest, Dr. Rangila Sinha Madam and Jyoti Bindal Madam, for blessing this webinar. And we are really thankful for devoting your time for this obstetric emergency webinar. And let's begin our academic session. And for that, the first topic is occipito posterior, and it is really a common situation, and how we are going to handle it. It will be spoken by none other than Dr. Archana Basir Madam, and for that we are having chairpersons, Dr. Pragya Mishra Madam. Dr. Pragya Mishra Madam is well known in Foxy. She is past vice chairperson, Genetic and Fetal Medicine Committee, Secretary General ISOPAP 22 to 26, and ICOG Governing Council member. Right now, Dr. Pragya Mishra Madam is President, Patna OBGY Society. She is Founder Secretary, Bihar Chapter of ISAR, and co-opted member of E-Zone Fellow Representative RCOG. And she had been awarded many times by George Mahoney Award, C.L. Javeri Award, Dr. Jagdeshwari Mishra Gold Medal Award, MP Zone Gold Medal, and so many times she had been awarded. So I welcome you, Dr. Pragya Mishra Madam. We are having our next chairperson, Dr. Bibha Verma Madam. Madam is President of Muzaffarpur OBGY Society, and she is President Rotary of Muzaffarpur and Secretary Cancer Awareness Society, Muzaffarpur Society. So we welcome you, Dr. Bibha Verma Madam. Next chairperson is Dr. Bibha Chaudhary Madam. Madam is President Bhagalpur OBGY Society, and very loving nature. We have attended Bhagalpur conference, and we enjoyed your hospitality, ma'am. So I welcome you, ma'am, for this to chair this first talk by none other than Dr. Archana Basir, ma'am. May I request our chairperson to invite Basir, ma'am?
I am Dr. Vibha from Muzaffarpur.
Hi, Dr. Vibha.
Thank you. Pranam. Dr. Archana Basir Madam is very well known to us, and she is a chairperson.
I think, Dr. Vibha, I'm being introduced. So thank you so much. We can just start with our presentation. Is that okay?
Yes, yes.
Hi, Prachi. So can I be allowed to share my screen, please?
I think Sudeep ji, Dr. Vibha's name has to be corrected.
Yes, my name is being written as Lata Gupta.
Yes.
Because she's your close friend, so that's why they have put your name as Lata Gupta. Thank you so much for kind introduction and allowing me to start with presentation. Before I start my presentation, I think Brajbala was not introduced. She is the secretary of MP ISAR, and the very hardworking secretary which I have as a chairperson MP ISAR, and she is currently the chairperson Environmental Committee Foxy, and she's been working very well to make our environment safe for us. So thank you, Brajbala, for starting with this scientific session. And my topic is very simple. And this is a topic which many of us have faced, and we all have dealt with occipital-posterior position. There is nothing new, but just we are going to revise few things, and I'm going to give tips and tricks how to diagnose and how really to handle with occipital-posterior position. So, like, what has been taught to us, for good outcome in labor, you need power, passage, passenger, and a push by the obstetrician. That is the determinant of good outcome in labor. So, what is the role of obstetrician in labor? Every labor is a challenge. I tell my students, my juniors, that every women in labor takes your exam. It is a challenge. As an obstetrician, we always have a big responsibility to hand over a healthy baby to a happy and a healthy mother. It is important we constantly update ourselves with the basics also. We are living in the era of artificial intelligence, but artificial intelligence will also still need the human brain to interpret it and guide it. So what is the goals and objectives of my lecture here? What is occipital-posterior position? What are the problems in occipital-posterior position in labor? How to diagnose OP, mechanism of labor, delivery, and take to work point. These are the simple things. So let's just have a revision. What is position? Relation of denominator to quadrants of pelvis. So this is sacrum, and we divide pelvis into 4 quadrants: right anterior, right posterior, left anterior. And this is the right to left transverse, this is symphysis, this is anterior, and this is posterior. Very simple way to see, learn. And this is the left occipital transverse position. Here is the anterior fontanelle, there is a posterior fontanelle, and this is the left occipital transverse position. This is it. Now, if you see what is the right occipital posterior position, the occiput is on the posterior, closer to the sacrum, and this is the right occipital posterior, this is the left occipital posterior position, and this is the persistent occipital posterior position, OP position. And these are all occipital anterior positions. We always are happy when we see the baby in the anterior position, right occipital anterior, left occipital anterior, and this is the right side and the left side of the patient. And this is the occipital posterior positions. These are the landmarks in the pelvis. I know that all obstetricians are there and all senior obstetricians are there, but just very quick revision of OP, OA, and this is all transverse position, and posterior and anterior positions is there. And this is how is a representation in the books of left occipital anterior, left occipital posterior, left occipital transverse, and ROA, ROP, and ROT. Now, let's move on to occipital posterior position. It is defined as when the vertex presentation with fetal back directed posteriorly so that occiput lies in one of the posterior quadrants, and incidence of occipital posterior position is 10% at onset of labor. It can rotate to anterior position during labor. ROP is 5 times more common than LOP. The left oblique diameter is reduced by the presence of sigmoid colon, and dextrorotation of uterus favors occipital posterior when spine is on the right side. So that's why ROP is more common. And this is in the mal position, that the ROP position, back is posterior and your occiput is here near to the sacrum. Now, what are the problems of deflexed head? What happens with the deflexed head? The presenting diameter is larger, and all problems of ill-filling the presenting parts. Now, what happens if the patient has a occipital posterior position? We have been taught that the labor begins 2 ways, either with the pains or with the leaking. So invariably, it is more common when it is occipital posterior position. Labor begins with spontaneous rupture of membrane rather than contractions. So you should, your red flag, or you should start thinking about the occipital posterior position when you have a woman who comes with the spontaneous rupture of membrane and she's having a prolonged labor, or the labor is difficult. There can be a problem of sepsis in occipital posterior position. Trauma and atonic PPH is again common with the occipital posterior position, and birth asphyxia is also more common with the occipital posterior position. So let's look at the diagnostic tips, how a resident can diagnose or how we can suspect and diagnose occipital-posterior position. What I have observed in the clinical practice means from history, a woman is repeatedly visiting a term with the backache and increasing vaginal discharge. She comes to you again and again towards the last weeks of her pregnancy, increasing backache, increasing vaginal discharge. And when you do palpation at the umbilical grip, you find that the back felt with difficulty in the flank away from the midline, and the anterior shoulder is at least 3 inches from the midline. The limbs are easily felt near or both sides of the midline. So basically the back is posterior, giving more problem to the patient, and she's coming repeatedly to you with the backache. Now, how you diagnose it? By the first pelvic grip, head is usually not engaged due to deflection. So when you say 5x5, 3x5 or 4x5, in the occipital posterior position, head is not engaged, so the full head you will feel is not engaged into the pelvis. The head is felt smaller by palpating fingers. Catch the bitemporal diameter instead of the biparietal diameter. And second pelvic grip, the head is usually deflexed. So this is the normal position and this is the mal position. This is the diameter. When you will be palpating by your pelvic grip, this is the diameter you are going to be, what you do in the poly grip. This is the diameter you will be palpating, and this is the normal, which is a little broader. Auscultation, FHAs are heard in the flank away from the middle line, and on vaginal examination, cervix is 2 to 3 centimeter dilated. It is not well applied. Presentation in clinic with false labor is more often in occipital posterior position, and keep a close watch on such pregnant women near the term because the false labor is more common. Now, what is the mechanism of labor in occipital posterior position? Head engages through right oblique diameter in ROP and left oblique diameter in LOP. The engaging transverse diameter of head is biparietal, that is 9.5 centimeter, and anterior posterior diameter is either suboccipitofrontal or occipitofrontal 11.5 centimeters. What happens in favorable cases? Good uterine contractions result in good flexion of head. Normal descent occurs up to the pelvic floor. Occiput rotates 3/8 of a circle, that is 135 degree anteriorly to lie behind the symphysis pubis. Shoulders rotate about 2/8 of circle to occupy oblique diameter, and rest of the mechanism is like that of right occipital anterior in ROP and left occipital anterior in LOP. So in majority of the cases, in favorable cases, this is what is going to happen, and OP is going to turn into OA, and it is going to happen. So this is the OP with the 3/8 of the circle. It is going to become going to become anterior, and the labor will follow. So this is how the rotation will happen. And now what happens in unfavorable cases? The 10% of the cases of occipital posterior position, occiput fails to rotate, deflection of head because of the weak uterine contraction, flat sacrum, prominent ischial spines, convergent side walls, weak pelvic floor muscles, big baby, and early drainage of liquor, because they begin with spontaneous rupture of membrane and the liquor is not there, so rotation doesn't happen. So what is the result in unfavorable cases? One of the following will occur. Long internal rotation, 3/8 circle, occurs in about 90% of cases, and delivery is completed as in normal labor. Direct occipital posterior position like face to pubis occurs in about 6% of cases, and head can be delivered spontaneously or by aid of an outlet forceps. Episiotomy is done to avoid perineal laceration, and deep transverse arrest happens in 1% and POP in 3%. Now, let's move on to the course of labor. Average duration of both stages of labor, first and second, is increased. First stage, engagement is delayed, persistence of deflection of head, driving force transmitting through the fetal axis is not aligned with the axis of inlet. Early rupture of membrane occurs, abnormal uterine contraction, and in second stage, delayed due to long internal rotation or malrotation, and with 8 times arrest of head. And third stage, increased incidence of postpartum hemorrhage and trauma to genital tract because of the prolonged labor and multiple times handling to see for the positions and whether the head is coming down and rotating. Now the tips for safe delivery. Early diagnosis so that actions are taken in time. strict vigilance with watchful expectancy, hoping for descent and anterior rotation of occiput, judicious and timely interference if needed, and early cesarean section. Partogram, the first stage is managed as in normal case. Nothing can be done to correct malposition or to influence the rotation of the head at this stage. A partogram is done. We know to monitor uterine contraction, fetal heart, dilatation of cervix, and it is a very important thing that we should keep partogram and learn to keep partogram because it's a documentation for future if any problem occurs at the end of the labor. So it's very, very important. Now, what should be our course of action once we have diagnosed and that it's a occipito-posterior position? If progressive cervical dilatation does not occur, augmentation with an oxytocin drip to be done. If still no progress obtained in a few hours, C-section is performed. Also, if there is a fetal distress, cesarean section is done. So this is a fate of occipito-posterior position. Engaging diameter is occipito-frontal, favorable 90%, 3/8 of rotation, occiput comes under symphysis and normal vaginal delivery. Unfavorable 10%, mild deflection, occiput rotate by 1/8 of circle, deep transverse arrest. If it's a moderate deflection, non-rotation, occipito-posterior arrest. Severe deflection, occiput rotate posteriorly by 1/8, POPP, occiput or sacral position. Either it can happen in phase 2 pubes delivery or arrest. So basically, it's good either it rotates posteriorly or it rotates anteriorly. Otherwise, you will have a trouble delivering the baby. So this is a deflex head in a DOT, what you call deep occipito-transverse arrest or possibilities in direct occipito-posterior. There can be phase 2 pubis delivery, delivery by flexion with that uterine contraction and no contracted pelvis, but perineal lacerations are more liable to occur because of the vulval stretching is more, it is distended by occipito-frontal diameter and the perineum is overstretched by the larger occiput. So this is occipito-anterior position with a flexion, the head is going and it is in the occipito-posterior position, deflection of the baby's head, so the larger diameter is stretching the vaginal entrance and that's why the trauma happens. Now, how to manage labor in POP? First stage, exclude contracted pelvis, which is by doing your examination, pervaginal examination, palpating the ischial spines and all, and exclude presentation of or prolapse of the cord. Inertia and prolonged labor are expected. So oxytocin may be indicated unless there is contraindication. Avoid ARM, that's the main thing, and monitor closely. Assisted vaginal delivery by vacuum extraction, proper application as near as possible to the occiput will promote flexion of head and traction will guide the head into pelvis till it meets the pelvic floor, where it will rotate. Manual perineal protection always, and episiotomy nearly always in occipito-posterior position, though we say in primary gravida there is to be elective episiotomy, but if it is occipito-posterior position, episiotomy is must. What are the alternative methods to us in delivering the baby? Manual rotation followed by forceps extraction, forceps rotation and extraction, or C-section. Now, operative vaginal delivery prerequisites. Safe operative vaginal delivery requires a careful assessment of clinical situation, clear communication with mother and relatives, and expertise in chosen procedure. You can either use forceps or you can use ventouse, but you should have an expertise in that particular method, whatever you are choosing, so that the chances of failure are less and you are confident. I'm not going into the detail because my friend Dr. Poonam is going to take about, the art of instrumental delivery. Let's move on to the cesarean section. It may be difficult C-section. Emergency when senior members are not around. This is a very common happening. Whenever there is an, such kind of emergencies are there, they happen either in the night or they are late in the evening when senior members are not around, like out of office hours. Deep transverse arrest, persistent occipito-posterior position, and reverse rotation and arrest. I'm just coming up with one case of occipito-posterior position and explain you like how it is to be managed. This is AMK, 27 years, 67 kg, primary gravida, conceived on subfertility treatment, uneventful antenatal period, spontaneous labor at term. She was progressing very well till 9 centimeter. Patient came again on a Christmas day, a holiday, was there with us, and it was a Sunday as well, and with almost perfect condition for vaginal birth. What happened next? 1.4 hours, no descent, oxytocin on flow, no place for rotation, fetal bradycardia down to 80 beats per minute. So how we manage the situation? Of course, you have to do C-section. Impacted head, which is a most common unexpected problem. Peritoneal incision has to be given higher up to avoid the bladder. Gentle pressure to widen the incision, because whenever you are doing a second stage cesarean section, the lower segment is echymosed and it is really very easily it can be torn. So the pressure should be very light. Shoulder was it incision, there was thick meconium, and assistant at bottom and gently push the head towards incision side. But very important thing, and I put it in the bold, not to push head before you try an incision, otherwise you'll end up in bladder. Other techniques have to be done like Patwardhan and all. And final challenge is to suture the uterus, because it becomes very, very friable. So it has to be very carefully sutured when you are doing a C-section in the second stage. So the tips for safe C-section is call for help. Do not like you may be hero, you may be handling the patient, you might have done hundreds and thousands, but it's very important to have one more person to help when there is a difficult labor. Take larger skin incision, do not try to have a small incision. Uterine incision has to be taken little higher up. Extend incision with scissors rather than manually if needed, and consider alternate methods such as forceps, Patwardhan in case of difficult head delivery. Now, this is a second case, multipara, expect the unexpected. I mean, what happens when you're delivering a G3P2 who has a previous vaginal delivery with an adequate pelvis? You would never, you will just say, okay, she'll deliver fine. She already has 2 vaginal births. This is a woman who came in spontaneous labor at 5 centimeters. ARM was done because the head was engaged. Good contractions per abdomen. Position could not be ascertained because she was little obese. Good contraction to begin with, no descent occurring and contractions fading. Caput developing, pitocin was started, fetal distress, large baby, POP failed, rotation, large baby. So basically, there was we had to do a C-section. So what I'm trying to tell, that we have to really make a decision faster. We cannot just say, well, that this patient has a previous vaginal birth. We are trying to reduce the cesarean section, but safety is also very important. So quality and safety in the second stage labor in OP. Concerns are mother and baby. Options: normal physiological birth, operative vaginal birth, or perform emergency C-section. So take to work message is identify the problem in time, use partogram to pick up the slow progress. First, support normal vaginal birth, assess for trial of operative birth, train in instrumental delivery. It is never too late. If not appropriate, know how to perform safe C-section in second stage of labor. That's what is the message I want to give here, that it is very important to do a safe C-section and a good instrumental delivery. So thank you very much to one and all for patience listening and being here with us today. And coming together is beginning, working together is progress, and trusting each other is a success. So thank you very much for giving me opportunity, and on a very simple but very common topic, which is being which we really need to face every day.
Thank you, Archana Madam. It was very well illustrated and very easy to understand. Pictures were also very good. I think juniors will find it good to learn in the labor room.
Dr. Vibha, thank you so much for the kind words. And that is the whole objective of this series, that obstetric emergencies, just keep us simple. And what I said in the beginning, we really need to brush up our routine topics as well, because in an auto mode, we are in an auto mode, and sometimes in auto mode, we forget to do few things because we take it for granted. So it's important. So thank you so much.
Thank you.
Thank you, Vibha ma'am. Thanks for your comments and thanks for chairing the session. Now I request Dr. Sushmita. Thank you, Basir ma'am. It was excellent, concise talk. on this occipito-posterior position? Sushmita?
Yes. We will have our next speaker, Dr. Poonam Dikshit, and the chairpersons are Dr. Professor Kumudini Jha, MD, PhD, DNB. She is ex-HOD, Obs Gynae Society, Darbhanga Medical College and Hospital. President, DAOGS, Darbhanga. Past Clinical Secretary, DAOGS, Darbhanga. Papers in national and international journals. Faculty in FOXY conference. Presented papers in several national conferences. And she has been a speaker in several CMEs, examiner in undergraduate and postgraduate exams. We welcome you, Kumudini Madam. Our next.
Thank you so much.
We have
Next
Dr.
person
Sumitra
is
Yadav, ma'am.
Manju Sinha ma'am. She is the president, MOGS Gaya. Consultant, Nisha Clinic, Katari Hill Road, Gaya. Life member, FOXY and IMA. Worked as honorary consultant at Military Hospital, Gaya. We welcome you, Manju ma'am. Dr. Lakshmi Sen ma'am, she is senior consultant, president of Katihar Obs Gynae Society, and she is the FOXY member and member of IMA. We welcome you, ma'am, for the next talk, and would request you to please introduce our next speaker, Dr. Poonam Dikshit from Patna.
Can I please introduce Dr. Poonam Dikshit? Can I have a CV? Hello? Can I have the CV of Dr. Poonam Dikshit, please?
Actually, we tried to collect Madam's CV, but somehow we couldn't. So,
okay, I'll introduce you from whatever I know. First of all, a very good evening to the Shrinkala team, Dr. Archana Paser, Dr. Brajbala, a very sweet person, Dr. Shushmita, and Dr. Prachi. Thank you so much for giving us this opportunity to join this webinar. And as far as I know, Poonam Dikshit, she's a very dear friend of mine. And I can describe her as a very down-to-earth person, a very humble person, and equally knowledgeable. And it is a pleasure connecting with her. She is an MRCOG examiner because she's so knowledgeable and she's so cool. The topic of her talk today is instrumental delivery. And this is a very valid topic for the current obstetric practice when everyone is just jumping down to cesarean for the flimsiest of reasons. The instrumental delivery has gone into disrepute because of the lack of training of the new residents, the PGs. Many of them have not seen it. We used to see the Killen's forceps, the rotation done. And because of the medical legal problems that are coming up every now and then, and because of the small family norms, people don't want to take any risks with the, if there is any chance of a risk on the baby or the mother, they refuse to have a vaginal delivery. And some of them are so sophisticated that they refuse to push. So it has its own place. So everyone should know, whoever is using the instruments should know the criteria for its use, like for the forceps, the rotation has to be complete, dilatation has to be full. So there are many other criteria which all of us should know. And there is a place like in, say, you have a cord prolapse and it is fully dilated. Then there is a place for forceps. Then you have, say, there's a fetal bradycardia, 80. And the baby is passing meconium and she has come into the labor room. So obviously you would like to use forceps instead of wasting so much time in preparing for cesarean. And there's a place for prophylactic forceps, like you have when the patient is in severe PET and her dilatation is full, she has fulfilled the criteria for forceps, or she's an eclamptic patient, we want to cut short the second stage of labor, like in TOLAC, previous cesarean, you are giving a vaginal birth.
And now we hardly have any cases, but we used to have cases of prolapse repair who were going into vaginal delivery. So we should know the criteria as well as the complications of these instrumental deliveries. There could be, if you give too much of pressure, then there could be intracranial hemorrhage in the baby. There could be very bad lacerations and third-degree tears in the vagina. And there are now better devices because that forceps that pulls at the level of the cranium. But the recent vacuum cups and the Odon, they give a traction only on the scalp. So that is less traumatic. And whenever you use an instrument, you have to take consent from the patient prior to applying it. And you should not only know when to apply, but equally important is to know when to stop. If there are 3 pop-offs, you don't carry on pulling on. If you're applying too much of pressure, you can't use both hands and someone pulling you from the waist behind. And when you're applying a forceps, that is too much of pressure. So we should all know how to apply, when to apply, and when to stop. Now we are updating, everyone says update yourself with the newer recent developments, but it is equally important to update ourselves with with what we have learned as residents. And that is exactly what Dr. Poonam Dikshit is going to do. So we are going to hear from a learned speaker about all this and much more. So over to you, Dr. Poonam. Can we have Dr. Poonam's talk?
And Dr. Sushmita and Dr. Poonam ma'am had joined or not?
Yeah, we are unable to see her. I don't know. Because many times we can see the same name in 2-3 places. So can we just move on with the panel? In between, we can just ask her to join.
Okay, so can we request Dr. Sumitra Yadav, our President IOGS, or do we have Dr. Yeah, Dr. Sunita is there. So to invite moderator then?
Yes,
Dr.
ma'am.
Poonam.
Yeah. I'm Dr. Sunita Chauhan, Secretary Indore Option Gynae Society. I invite Dr. Sushmita Mukherjee to conduct the panel on adrenaline rush in labor room and OT. And she is light member FOXI, ISAR, IFS, IMS, IG, IMA. She is advanced laparoscopic surgeon doing IVF and high-risk pregnancy. She is a national faculty at AICOG, IAG and IFS. She received IFS MP Star Award and ISAR Dronacharya Award. She is gold medalist from Kolkata University. She is executive committee member of IFS and IAG MP chapter. She is organizing committee member of ISAR, IAG and AICOG. I invite Dr. Sushmita Mukherjee, madam. And the second moderator is Dr. Prachi Singh. She is consultant at Ashirwad IVF Center, Muzaffarpur, Ayushman Hospital and Endoscopy Center, Muzaffarpur, Bihar, East Zone Coordinator of Endometriosis Society of India, Treasurer, AOGS VJ, and East Zone Coordinator, Imaging Science Committee, FOXI. I invite Dr. Prachi Singh, madam. She is founder secretary, ISOPROB Muzaffarpur secretary, MOGS, and past secretary, IMA, Muzaffarpur. Invite Dr. Prachi Singh to conduct the panel discussion.
Dr. Poonam is just logging in. I've just had a word with her.
Okay, then we can continue.
So shall we wait or shall we continue with panel first? Because
we got
messages.
Continue with the topic. She has joined.
I think Braj, let's listen to Poonam if she is joining in.
Yes.
Because she has just messaged me. Joining. She has said the joining.
Great, ma'am. So
thank you. My heartfelt thanks to Dr. Archana Basir, madam, to give me this opportunity. And I am very honored to be here with our chief guest, Dr. Jyoti Bindal, madam, and our guest of honor, Dr. Rangila Sinha, madam. Thank you, madam.
So can we move to our second talk first, instrumental delivery?
Poonam, are you here? can, or maybe we can just have, because she's sent the message she's joining, or she said in case I'm late you start the panel. I think
yeah, she has not yet joined.
So yeah, you can start the panel, Sushmita, and
Yes.
then we can have a talk. Yeah. Okay.
For the panel, I will request Dr. Tina Gupta, senior gynecologist from Bhopal with her own IVF center and hospital, to introduce experts of the panel. So, Dr. Tina.
Yeah. Thank you, ma'am. And after this wonderful lecture on POP, let's move ahead to the wonderful panel discussion on adrenaline rush in labor room and OT. For this session, we invite our experts, Dr. Kalyani Singh, ma'am. She is President, Saharsa Society. Dr. Nibba Mohan, ma'am. She is Consultant, Renu Maternity Center, Patna. Honorary Secretary, Patna Obs and Gynae Society. Past Treasurer, Clinical Secretary, Joint Secretary, Patna. Next. Dr. Varsha Sinha. She is Secretary, Bhagalpur Society. Yes, ma'am. You can now proceed.
Please introduce the panelists also.
Okay, ma'am. Okay. So the panelists for this panel discussion are Dr. Amrita Anand. She is Secretary, Saharsa Society. Dr. Poonam Sahai. She is Secretary, Gaya Society. Dr. Anuradha Sinha. She is Secretary, Prunia Society. Dr. Vibha Verma. She is MBBS GNV gynecologist at Muzaffarpur. Resident Mox, Muzaffarpur. Dr. Lata Gupta, she is consultant in Lata Nursing Home, founder secretary of the Sitamarhi Obs Gynae Society, secretary of Sitamarhi Society. Ma'am, you can now please start the panel discussion on this wonderful, thrilling topic.
So, thank you, Basid ma'am, for giving us, me and Dr. Prachi, this opportunity to deal with the panel. Now, mostly we are busy with laparoscopy, IVF. Now it has been a very great opportunity to brush up my obstetric knowledge, because we don't get opportunity to read all these things. And she has been instrumental in bringing this topic, and definitely we had to read it thoroughly. So now adrenaline rush in labor room and OT. We have grown in labor room. We obstetricians, we were born in the labor room. We are obstetricians because labor room is there. And we all know how it feels when lot of emergencies arise in the labor room, and many times even 1 minute before we don't know what is going to happen. Such may be the emergency situation. So may I have my presentation? Now, as the topic suggests, it's fight or flight response, a do or die situation in the labor room where both mother and baby are at risk and can have both positive and negative effects on the labor and birth. Well, prompt diagnosis, early intervention, decision-making is rewarding. Next slide. The first case is a 24-year-old lady who enters labor room with history of sudden leaking. She has 2 previous vaginal deliveries. Now she complains of something coming out per vagina, and the patient is rushed to the labor room. Next slide. Now, such is the case, I would request our esteemed panelists that what will you suspect and what will be your first response in such a case? Dr. Bibha, Dr. Lata, whoever wants to take the.
Yes, madam.
I will
take this
like to
question.
suspect cord prolapse in this case, and
Yes,
immediately I will be doing to confirm this PB examination. I will get it confirmed by this.
yes, ma'am. Thank you. Definitely, we can make out that it is most probably something is coming out. So it is the cord, most probably, and there has been leaking. Now, the first response which would come from us is to reposition the cord. That is,
Yes, reposition of the cord with piece of gauze so that the temperature is maintained and it doesn't go in spasm. And next to confirm with ultrasound whether the baby is viable or not.
the clarification with this step is that it is better as per RCOG guideline and practically also better not to touch the cord. As far as possible, push the presenting part and elevate the lower part of the pelvis of the mother. Because we don't want the umbilical artery to go into spasm. That is the whole idea. But definitely, Viva madam, using a warm saline gauze will help. It will prevent spasm and it will help in repositioning. The main message here is because it is an instinct that immediately one would jump and touch the cord and put it and push it, which should never be done because that will initiate umbilical artery spasm and imminent death of the fetus. So that is the message that was the point for keeping this question.
I think we should make the bladder full in this such cases.
Yes, we will be covering. Next slide. Next slide. So you all know the cord. Can somebody explain the different types of cord prolapse and what is the difference between the presentation and cord prolapse?
Yes, madam. These are three types. One is cord presentation. Another is occult cord prolapse when we can feel the pulsate membrane. So there is no immediate danger. And the most worst part is third one where the cord is lying in the vagina or outside vagina. And here fetal mortality rate is very high.
Yes. And what may be the other cord problems which we may encounter in obstetrics? Other problems with the cord?
You can have a true
These
knot,
are true knot,
short cord, long
Yeah.
cord around the neck. When it can be cord
And
around the neck.
yes, thank you. There may be some change in the consistency of the cord, which will make it more prone to prolapse. The turgidity is less, the Wharton's jelly which is present within the cord may be less, and all these things make it prone to more prolapse. Now, in case of cord prolapse, the fetal mortality can be as high as 10%. The incidence is 0.1 to 0.6% of all pregnancies, and 1 in every 300 to 500 pregnancies, there can be cord prolapse. Next slide. Now, what are the risk factors where one should be aware and counsel the patient that this kind of a situation can happen? So, what are the conditions? We all know.
Yeah.
Whenever there is excessive hydramnios, multiple pregnancy, when the presenting part is very high,
yes,
and with little excessive liquor, you should never do ARM because there are chances of cord prolapse.
Excellent. There is a guideline from RCOG that you are not supposed to do amniotomy if the presenting part is not fixed If the presenting part is high up, if there is a malpresentation, if there is polyhydramnios, in all these cases, you are not supposed to do an amniotomy unless you have everything ready for cesarean. So it should be done in a place where things can be managed immediately if there is a need for cesarean delivery. That is the guideline. So next slide. So what are the conditions where we can have cord prolapse? There can be while doing iatrogenic amniotomy, external cephalic version, intracervical balloon, and amnioinfusion. Next slide. So I have few questions on what one should do and one should not do in cord prolapse. So just very short answers we need. Would you handle the cord? Yes or no? No.
No.
Push the presenting part up? Yes
No.
or
No.
Yes, yes. With
yes.
inflating the bladder, we can push the presenting part up.
Bladder we can.
Yes, we should push the presenting part up. Now, knee chest position, yes or no?
Yes, it can help.
So, if the patient is at home, she's away from hospital, this is one position which she can be explained, or in high-risk cases, you can explain it antenatally, that in case of sudden rupture of membrane, you can take this position. Is Trendelenburg position indicated?
Yes, madam.
Yes. Left lateral position?
Doubtful.
No, it is also a very good position. And while the patient is being transferred in the transit, left lateral position is very important because it is bit comfortable for the patient to be in that position. Knee chest position is not that comfortable for a pregnant mother. And during the transit, oxygenation of mother is important.
Yes, 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 it is very important.
Yes. Next slide. So will you allow vaginal delivery and when?
If the dilatation is full and we can expect that it will occur within 5 minutes, then we can allow. Otherwise, if the dilatation is not proper, we have to do immediate cesarean section if the baby is alive.
Yes. So before doing a cesarean, what most important thing you have to see?
Fetal heart.
Baby is alive or not?
Yes, yes, you have to see the fetal well-being, whether the fetus is doing well, what is the, even before giving the incision over the abdomen, one has to check that the fetal heart is there or not. Because with a dead baby with a cord prolapse, usually we will be avoiding cesarean section. Does prolapse lead to immediate death of the fetus?
No, it gives us 5 to 10 minutes.
Yes.
10 minutes.
Usually we get some time, and if the mother is properly maintained with oxygen and IV infusion and everything, and continuous CTG monitoring of the baby is done, all these things, we get some time if we are not manhandling the cord. So bladder filling helps.
Yes, it helps.
So bladder filling definitely helps, and if sometimes the primary healthcare workers are given Foley's catheter, they keep it, and in the home setup they fill it up. But definitely while you are delivering the baby, you have to evacuate it. So warm saline pack helps, you have already mentioned.
Yes, yes, it helps.
Yes. Do tocolytics help?
Sometimes it helps.
Yes, when
because it will prevent cord compression.
Yes. Yes, it will prevent the presenting part to go down and compress the cord further. So that is the idea of giving the tocolytic. Now, since left lateral position helps or not? Yes, we know it helps.
Yes, it helps.
Yes, yes.
But everything here has to be done very quickly, ma'am.
Yes.
Yeah,
Yes.
without taking much time, 5 minutes you have to be in OT.
Thank you. Next slide. So these are the precautions during transit. Next slide. How will you prevent cord prolapse? So what will
Avoiding unnecessary amyotomy. ARM should be avoided unnecessarily for induction of labor.
Yes.
Nowadays we have the opportunity to do ultrasound, so we can with this help of ultrasound we can make out whether the cord is near the cervix and all. We can make out, so we
Yes.
can be make careful. Only in unbooked cases, then this will be a problem, cord
This is
prolapse.
absolutely right. Next slide. Next slide. So the golden steps are: keep the pelvis up, avoid vasospasm of cord, avoid hypoxia of fetus, prompt delivery, prevent by judicious amniotomy, take care in transit, and counseling antenatally in case of high risk factors. Next slide.
Yes.
Now, RCOG Green Top guidelines say that the purpose is to prevent, diagnose, and manage cord prolapse. Awareness regarding factors which may lead to cord prolapse is important for the clinicians to understand. Ultrasound is not so sensitive in diagnosing cord presentation, and it should never be used to predict cord prolapse. There may be a suspicion, but we cannot take ultrasound as the last thing to predict it. Breech opting for vaginal birth should undergo ultrasound for screening. Next slide. And those with transverse lie, multiple pregnancy, malpresentation should report immediately to hospital if there is anything like membrane rupture. And with high presenting part, avoid amniotomy. And if there is a need to do amniotomy in such case, can be done with everything ready for cesarean section. Next slide. No unnecessary delay. Don't wait much in managing the cord. Pushing the presenting part is a good practice. Multidisciplinary approach to manage the case is important. This is most important because in such a case, the role of a very senior neonatologist is very, very important because this baby will need
resuscitation.
Resuscitation. Good neonatal care is a must to prevent asphyxia of the fetus and prevent stillbirth or cerebral palsy and birth asphyxia. Next slide. Avoid amniotomy if you feel the cord below the presenting part. Also in cord presentation, better to go for cesarean section. Fetal heart sound checking after every membrane rupture and after every vaginal examination, especially when the fetal heart is going abnormal. Repositioning of the cord is not indicated. Pushing it above the presenting part and allowing normal delivery is also not indicated as per the guideline. Next slide. So now we move on to the second case. Quickly, we will be covering a 30-year-old lady visits hospital with 34 weeks pregnancy with severe pain, abdomen and bleeding TB. Pedal edema present, her BP is 170/100. Right?
It's a preeclampsia with abruption.
Accidental hemorrhage.
How will you manage?
Abruption placenta.
So it is a case of antepartum hemorrhage with where the BP is high. So most probably it is a case of antepartum hemorrhage.
Yes.
With abruptio placentae.
Placentae.
So how will you proceed with the patient?
We will take the history. Is there any history of injury or was she smoking or how much her parity? She may be grand multipara, and we will examine. The uterus will be tender, and fetal heart sound may be audible or not, may be absent. we should ask for CBC and viral marker anything, because we may need to take her to OT, and we have to resuscitate the patient and do an ultrasound and see the viability position of placenta. Although accidental hemorrhages sometimes it is not easy to see in USG by us. It may be possible that if an expert sonologist is doing ultrasound, he will see, but it is difficult for us to diagnose accidental hemorrhage on USG.
Yes.
So we
yes,
have to manage
excellent.
the case accordingly.
Excellent. Excellent. Next slide. So, abruptio placentae, 35% of antenatal bleeding is due to this. Recurrence is 5 to 17%. This is very important. One abruptio, next time the incidence is as high as 5 to 17%. And after two abruptio, the third time the incidence will be as high as 25%. So, this is one point where you can predict abruptio. A patient who already has a history of abruptio might have abruptio in her next pregnancy. Now, elderly, preeclampsia, chronic hypertension, multiple pregnancy, these are the high risk factors. And also a patient who is smoking, cocaine abuse, prior abruption, uterine leiomyoma, hydramnios, they can also land up with abruptio placentae. Now, there are broadly two types, the concealed and the revealed types. Next slide. Now, what are the signs? We all know bleeding, 80%, tenderness, 66%, back pain, fetal distress, and sometimes fetal demise that is as high as 15%. Next slide. Now, if you can please explain what are the different types, and because the management entirely depends on the types and the grades of abruptio. Although
Yes,
it's
madam.
more of a clinical diagnosis and overall assessment of the patient, but definitely the grades will help you to decide how you will manage that patient. So somebody please explain what are the grades?
Grade 0 is asymptomatic retroplacental clot. In grade 1, you have vaginal bleeding, but no fetal or maternal compromise. There is just a mild uterine tenderness. And in grade 2, you see fetal distress is also there, but there is no maternal shock. In grade 3, you have fetal demise, maternal shock, severe uterine tenderness, and you can find deranged blood parameters. There might be concealed or revealed vaginal bleeding might be present. So these are the types of abruptio placentae.
Thank you, ma'am.
Yes, one thing I want to add, in grade 3, urea will also be there, and FDP will be increased, and the fetal demise is a rule in grade 3, and patient will be with very high pulse rate, and BP will start falling now.
Yes, yes. So next slide. So as we can see,
madam.
yes.
Madam, I'm sorry to interrupt. We had one other panelist, Dr. Varsha. I think her name is not mentioned. She's also joined. So I think Dr. Varsha
No.
is a panelist also.
We have mentioned, but that time I think she was not there.
No, there was some confusion. She is Dr. Varsha Nathani from Muzaffarpur.
Okay, most welcome.
So she is there.
Most welcome.
Varsha, you can join, please.
Please give your inputs. We are in the middle of the panel. Now, abruptio, so we have gone through the grades, and now a patient who can abruptio lead to DIC, and how and when. So somebody can take this.
Yes, because all coagulating factors are consumed. So DIC may result if the size of clot is very big.
Yes, it can lead to DIC, and it is more in the concealed type. Now, what is pulmonary uterus and how do you diagnose it?
Covular uterus, where you open the abdomen and you see it is blackish, greenish, starry uterus because of extravasation of blood from placenta into the myometrium, and it comes in the subserous area.
So it is a visual diagnosis. Ultrasound is not going to help. Now, a patient, such a patient, when she comes, will you be doing vaginal examination? Yes or no, and why?
Yes, I will do vaginal examination. If the dilatation is there, I will do an ARM so that
we can give her normal vaginal delivery if it is not a severe form of abruption.
No, the first thing is immediately one should not do a vaginal examination because it might be a case of placenta previa also. So unless you are 100% sure that it is a case of abruptio, that the placenta is not in the lower segment or covering the os, ideally, as per guideline, you are not supposed to do a vaginal examination. A speculum examination is allowed, and if possible, ultrasound or previous reports you can consult. Urgent delivery is life-saving for fetus and mother in all cases. So is it true or false? Hello?
Yes, it is true.
Urgent delivery is life-saving for fetus and mother in all cases. I have told
no, not in all cases. Not in all cases.
Yes. Because we know the grade 0 and grade 1, the minor varieties where there is a very small clot, retroplacental clot, the baby is fine, premature, mother is absolutely fine. There you can continue with the pregnancy. There is no need to deliver the baby. Definitely that, so the knowing the basic grades, the severity of the problem is important. Now, coagulation profile.
And we can also give medicine, betnisol for lung maturity of the baby if the grade is less.
Absolutely. Coagulation profile, fibrinogen levels, fibrin degradation products, are they indicated?
In severe cases, it's yes.
Yes, definitely. They are indicated, especially in cases of concealed one with severe tenderness and the patient is in shock, the mother, there is fetal demise, the things become very difficult to manage, and we need all these parameters. Next slide. Now, is anti-T indicated?
Yes.
Yes. In especially in the concealed variety, the chances of RH isoimmunization is very high. So immediately one should go for anti-D in such cases. Now, where can we continue pregnancy with abruptio and why? It is with the lower grades. We have already discussed. Now, where do we need to terminate immediately and why?
If the maternal condition is deteriorating, we need to terminate pregnancy because we have to save the mother first.
Absolutely. And also in cases
also the fetal conditions.
Fetus is, there is severe bradycardia, there is the maternal, in order to save the baby also we do cesarean in such cases, unless the baby is too premature, unless where viability is a problem. Mostly to save both mother and baby, we do a cesarean. Now, where cesarean is indicated as an absolute indication is where there is severe maternal, the condition of the mother is very
deteriorating. Yes. Condition of mother is deteriorating, she is going in renal shutdown, then we have to terminate the pregnancy and resuscitate the mother, and we have to give lots of blood transfusion.
Yes. And sometimes if the severity is not that and there is prematurity, you may have to you should give steroids, and that is crucial. So next slide. Can you predict abruptio placentae?
Sometimes, not
sometimes in
always.
preeclampsia it can happen. So
Yes, and if
where
there is a
conditions like
previous history of abruptio, one can predict that this time also there is a high incidence of it can happen. Can you
Yeah,
prevent abruptio?
if the BP is high, there is fibroid inside the
we said
or there is any history of injury, then we can suspect or we can give alert to the patient that if you have any sudden pain, please report to us.
Yes. Now, regarding ultrasound, Vita madam, will you please explain why ultrasound is not
प्रियंका बैठ जाओ, कितना देर खड़ा रहे?
not diagnostic for abruptio?
Because blood clot is always not very easy, and in the reveal type, we may not get any clear cut finding. But we can see that placenta is in upper segment, so we can exclude placenta previa. That's
It
final.
is beneficial, but it is not that sensitive. Now,
Yes.
is active, one last question, is active management of third stage needed?
Of course needed, because a patient with antepartum hemorrhage will go in postpartum hemorrhage.
Yes, yes. Next slide.
And we don't have much of patient is already anemic and we don't have backup. So we need to be aggressive in managing third stage of labor.
Yes. Next slide. So assessment of maternal and cardiovascular condition and fetal well-being following pain, abdomen and vaginal bleeding, interprofessional collaboration, obstetrician, hematologist, radiologist, intensivist, everybody needed. Shifting to
Yes.
ICU setting, blood cross-matching, antenatal interventions like folic acid, avoidance of smoking, etc. These are the RCOG guidelines which are important. Next slide. Thank you. So now I'm so thankful to the panelists who have participated, and I will request Dr. Prachi Singh to move on with her cases with a lot of adrenaline rush in the labor room, and I would also thank her for so much of help from the very beginning in conducting this series, this webinar, and she has helped us a lot. And thank you, Dr. Prachi. Now you can move on to your cases.
Thank you so much, madam, for your kind words, and I thank Dr. Archana Basir, madam. Because of her initiative, we could do this very informative CME, and madam, your talk was really wonderful and so well explained of such a difficult topic, I would say. So, Dr. Varsha, can you say something? So
Hello,
that I know
Prachi.
you're, yeah. So now you're unmuted.
Okay.
Okay. So I'll start my panel discussion, and my first questions will be on shoulder dystocia. So I would ask my panelists if anybody can answer, what is shoulder dystocia?
Shoulder dystocia is vaginal cephalic delivery, which needs additional obstetric maneuvers to deliver the fetus after the head has been delivered and genital traction has been failed. And the anterior shoulder dystocia is more common. It impacted behind the symphysis pubis compared to the posterior shoulder dystocia.
Yeah, so more common is the anterior one, and rarely the posterior shoulder, and sometimes both shoulders are impacted. And it is an really obstetric emergency, and it's difficult sometimes to treat also. So can you explain can you explain the mechanism of shoulder dystocia?
it occurs when the shoulders enter the pelvis with the bisacromial diameter in the anteroposterior diameter of the inlet instead of the normal oblique diameter.
Oblique diameter is the one which is more spacious. So when it enters the anteroposterior diameter, then there is a risk of shoulder dystocia. Is it very common in our labor room?
No, it's not that common.
Not common.
Incidence is 6 by 1,000.
0.6% to 1.4% according to ACOG, it says 1% of all deliveries. And are we having an increasing trend of shoulder dystocia? What do you think?
Not in everyone, but in diabetic women or
I came across this literature that said that maybe shoulder dystocia is increasing because the babies are now being born larger, and also maybe because of better documentation. Maybe that could be a factor. So what are the risk factors for development of shoulder dystocia?
Previous history of shoulder dystocia, it has tenfold increased risk of shoulder dystocia in the next pregnancy. And also diabetes, GDM or pre-existing diabetes is an important risk factor for the development of shoulder dystocia. Instrumental deliveries are common where shoulder dystocia.
So a baby who is born to a mother who is non-diabetic is less at risk of shoulder dystocia as compared to the same weight of the baby. If the mother is diabetic, then the baby is more at chance of developing shoulder dystocia because
yes,
of the
anencephaly is one of the important cause.
Yes, because the fat is deposited on the shoulders in case of diabetic mother, and therefore there are more chances of shoulder dystocia. And also mid-pelvic, I don't think anybody does mid-pelvic instrumental delivery.
Nobody.
But that is said to be a risk factor. So what will be the clinical features?
The
head will be slow progress.
So we might suspect if there's slow progress of labor or there is inability to deliver either shoulder with gentle traction. Also the turtle sign.
Yes, turtle sign will be there.
What exactly is the turtle sign? Can somebody explain?
Head is insinuated between both of the thighs, and you cannot give. It will not move forward even if you give.
It is
little
deeply
traction.
impacted. Like even if you want to put some fingers between the head and the maternal thigh, there will be no space. It is deeply retracted against the maternal thighs. So how do we diagnose?
When the head to body delivery is more than 60 seconds and there is no restitution, and there is after the delivery of the head, if the shoulder gets stuck at the vulval outlet, this is how we diagnose shoulder dystocia.
So I have a very good video I will show you all. So let's talk about the management. What will be the first line management? Suppose you have diagnosed a case of shoulder dystocia. What will be your first line of management?
To give a liberal episiotomy.
Call for help.
Yes, very important. Call for help.
Then we have to explain to the patient that shoulder dystocia has happened, and we have to ask for additional manpower in our labor room. And we have the senior obstetrician should be there, the neonatologist should be informed, and we should explain the patient that this has happened, and then the rest of the things has to be done. And then we have to go for the Mac-Roberts maneuver. And before that, we have to ask the patient not to push, and the fundal pressure should not be done.
Yes, it is very important that fundal pressure is not to be given because sometimes in a multiparous the uterus can rupture also. So it is important.
But you must have an idea of what is the actual fetal weight. If it is 4.55 kg, I will not try anything.
No, that much weight will not try. But sometimes it's not necessary that such a big baby will only have shoulder dystocia. Many times normal weight babies also end up in shoulder dystocia. So this is an unexpected thing that we might encounter. So very important, you have said, Varsha, that first we have to tell the patient also, because if we are having some difficulty, this will be a very good thing later on. Suppose if there is some medical legal problem, if we have explained to the patient and we have explained to her what is happening, then she will be more receptive. And of course, we have to do the Mac-Roberts maneuver. Please explain the Mac-Roberts maneuver.
In Mac-Roberts maneuver, the thighs has to be flexed, the hip joint has to be flexed, and the thigh has to be kept on the anterior abdominal wall, and it leads to the flexion and abduction of the hip joint, and which leads to the increase in the angle of the lumbosacral angle, and it also increases the anteroposterior diameter of the pelvis, as a result which facilitates the delivery of the shoulder.
So I think in this video, you can understand if you're abducting and you're hyperflexing the thighs. So what happens is that the sacral promontory goes down, the birth canal becomes straightened, and I'll play this video again. And the shoulder that was being impacted here, if there is flexion, see, if there's flexion, then what happens? You don't have to do it repeatedly. This is the video that is demonstrating. Just when you do it once, the symphysis pubis will rotate and then the baby will be born. And this is the Rubens maneuver. What is the Rubens maneuver, if somebody can explain?
We have to deliver, we have to insert our hand and we have to put our fingers in the axilla and we twist the hand in front of the chest and we take out it. And we twist the baby and we take out another hand in the same manner.
I think Rubin, one maneuver is you do the McRoberts. Along with that, you give suprapubic pressure. So when you do suprapubic pressure, both the shoulders, they will adduct and the anteroposterior diameter will reduce and the baby will be delivered. This is the Rubin 1 maneuver.
Oh, mine one was Javanelli.
So Rubin 2 maneuver. These are all maneuvers like we have to know. I'll place this video so that we can all understand. This shoulder is being impacted here and the head is retracting. So this is the turtle sign. We are hyperflexing the maternal thighs and then we are introducing the finger. The shoulder which is up, which is obstructing, we have to push it down. It looks very easy, but everything is impacted. It will not be so easy. But this is the Rubin 2 maneuver. And the baby hopefully delivers safe and sound. So some other maneuvers.
It is Cleidotommy, symphysiotomy, and Javanelli's maneuvers. And also the delivery of the posterior shoulder is also there.
What are complications? I think maternal fetal postpartum hemorrhage.
Yes, PPH, lacerations, third degree perineal tear, fracture. If the symphysis is broken, it is another problem. She will be have difficulty in walking.
Shoulder discharge is a really nightmare for obstetricians.
But we have to know about, and that is why we are having this very, I hope, a good panel discussion and everybody is understanding all the mechanisms. So we have some complications for the fetus also. In fact, the fetus is more at risk in this shoulder dystocia.
Fracture of humerus and abs palsy.
Brachial plexus injuries.
Yeah, because of traction on the head.
On
so
the
it
neck
is always important not to give undue traction on the fetal head. So Erb's palsy is when there is injury to C5 and C6, and Klumpke's palsy is when injury to C8 and T1. I think that is all for shoulder dystocia. And then now we'll be discussing the second case, which is postpartum hemorrhage. How much time do we have? Hello, is anybody there? What time do we have?
Yeah,
Doctor?
actually, we are supposed to conclude by 7.
Yeah.
If you want to cover, if you can cover fast.
Yeah, I will just do very fast. And I think
we have another talk.
Yeah. So what is PPH?
Any amount of bleeding from or into the genital tract following birth of the baby up to the end of the puerperium, which adversely affects the general condition of the patient, evidenced by the rise in the pulse rate and fall in blood pressure. This is postpartum hemorrhage.
So not the exact amount, even if a very small amount in a patient who is already anemic, that will also mount to postpartum hemorrhage. So what are the types of PPH?
It is primary and secondary PPH.
Primary and secondary PPH.
Primary PPH is the blood loss in the first 24 hours of delivery, and the secondary one is that is between 24 hours up to 12 weeks postnatal.
RCOG says up to 12 weeks. Normally it is said up to puerperium, which is
6
around
weeks.
6 weeks. So there's a little bit of difference there. So basically, primary PPH is within 24 hours and secondary PPH is after 24 hours till 6 to 12 weeks of delivery. What is the incidence of postpartum hemorrhage?
It is 2 to 11%, but I don't know. At tertiary centers, we have more cases of PPH because cases are very bad.
This may not be correct because I think the incidence is more.
This is according to I have taken this from the RCOG, but definitely in high risk patients it is more, especially in high risk patients. And in my centers, somehow I'm getting more of PPH, maybe because of all the IVF deliveries that are happening. Even during cesarean, I'm encountering some atonic PPH. But the important thing is that hemorrhage is still one of the most uh, common reasons for maternal mortality, and we have to reduce postpartum hemorrhage. So what would be the causes of primary postpartum hemorrhage?
Bone tissue trauma and thrombin. Most common is atonic PPH. Here, failure of uterus to contract after delivery, and we will see that uterus is soft and enlarged and flabby. And risk factors are overdistension, multiple pregnancy, obstructed labor, fetal macrosomia, uterine infection, prolonged labor, forceful delivery,
So
etc.,
in
and
these
IVF
patients,
pregnancy.
yes, in these patients who are at high risk, then we have to be really alert for the onset of atonic PPH. Although PPH can arise in any patient, but there are some factors which are at very high risk for developing atonia. The other prime cause can be traumatic PPH, around 20% cases, and others are retained placenta uterine inversion. So what are the causes of secondary PPH?
It is endometritis, retained product of conception, and sub-involution of uterus. Thrombophilias.
Coagulation disorders.
Very good. So as I was saying, we can predict PPH in some patients, like those patients who are at high risk. For example, as has been said, advanced maternal age, multiparity anemia, if this is there in the history, or in the antepartum period, there's multiple pregnancy, overdistended uterus, antepartum hemorrhage, or chorioamnionitis. And intrapartum, there is induction of labor, prolonged labor, instrumental delivery trauma, oxytocics have been used for a long time, and if there is sepsis, then all these patients are at risk of developing postpartum hemorrhage. Can somebody explain this table? Dr. Varsha?
Yes, ma'am.
Can you explain this table? What is this table?
Yes, actually, these risk factors are indicating about the tone and the tissue, the thrombin, and the tissue factor.
What is this saying is that which factor is most at risk of developing that particular disorder. So multiple pregnancy, this relative risk is 4.7, which means in multiple pregnancy, there will be more chances of developing PPH. Same with preeclampsia, there is more chances of developing postpartum hemorrhage due to thrombin problems. And again, retained placenta, if there is there, then there will be most chances of developing PPH. So this is that table. I've taken this from the RCOG. So can we minimize the risk factors for developing PPH?
Yes, we
of
can
course.
minimize.
We have to do a good antenatal checkups and improve the anemia of the patient during our antenatal checkups. And wherever the high risk is factor is there, we have to identify, and they should be advised to have the institutional deliveries. And when they are admitted, every case we have to think that she is going to have PPH. So in that we have to arrange for the blood, monitor her continuously, and any hypertensions, all these issues have to be dealt with. Then active management of third stage of labor is very important in the prevention of PPH, and we have to be gentle with the tissues, wait for the delivery of the placenta by cord, continue cord traction method, and then you have to watch the placenta and the membranes, any clots, any tears, and massage the uterus. So all these factors will definitely reduce the chances of PPH.
Yes, very good. Thank you. Active management of third stage of labor is very important. Can somebody say the constituents of active management of third stage?
Yes,
10
use of
unit of oxytocin, 10 unit of oxytocin just after delivery of the head, and control cord traction, and uterine massage has been excluded from this.
and delayed cord clamping is also there.
Delayed cord clamping, yes. That is
WHO still recommends this one, uterine massage, as one of its main this one.
although uterine massage for prevention of PPH is not there. It can be used for treatment, but maybe for prevention it is not so effective. So how is blood loss quantified? We all know that we are saying that if it is more than 500 or it is more than 1000, but how do we quantify that? What exactly is the amount of blood that has been lost?
Visual inspection, Kelly's pad, or what is the size of the pad? Is it whole soaked, half soaked? Whether there is any spillage on the floor? If it is spillage on the floor, it is more than 1500 ml loss. Kelly's pad is a good thing. It has a measuring scale on it, and it gives good idea.
And if there's one full kidney tray which is filled, then that is 500 ml. And there are some other methods also. Visual we have talked about. Other is the gravimetric method, in which we assess the blood loss which has collected. That can also be done, or volumetric, we can measure the blood loss. Photometric, which is total blood loss which is collected and hemoglobin is extracted. And colorimetric is the other form, where photographic and geometric information from relevant areas analyzed. So these are the various methods by which we can analyze the amount of blood loss. Coming to management, how do we manage a case of PPH?
Yes, in case of there are minor PPH or major PPH, so the management differs in both. For minor PPH, where the blood loss is between 500 to 1000 ml, we just have one IV line open, that is 14 gauge, and manufacture has to be done, and grouping, screening, full blood count, coagulation profile has to be done, and Meo's charting has to be done, in which pulse, respiratory rate, and blood pressure has to be monitored every 15 minutes, and followed by infusions of the crystalloid infusion.
Yes. So while we are arranging for maybe if the patient is bleeding too much, we are waiting for blood. At the meantime, we have to start warm crystalloid solution. And when we say that we have to do coagulation screen, so what are the methods like coagulation? What coagulation screen will you order? Normally, we were doing prothrombin time and activated plasma APTT. But nowadays, this is the new thing of thromboelastography and rotational thromboelastography, which is known as TEG and ROTEN. This is the new thing which has come up, and this allows rapid assessment of coagulation using citrated whole blood by measuring clotting factors involved in extrinsic pathway and fibrin in the formation of clot. So basically what they do is they put, this is a bedside test, they put blood in this chamber, and the resistance that this clot gives will give an idea about the level of clotting factors which are there. And this has been found to be very useful. And this is called rotational thromboelastometry, ROTEN or the TEG. So these are the two companies which are doing this. And they will measure whether the fibrinogen concentration is low or whether the extrinsic pathway clot rates are low. So management we have done. We have to also empty the bladder. We have to give a Foley's catheter so that we can measure the urine output. And if it is an atonic PPH, we have to give oxytocin 5 units by slow IV injection. ergometrin, oxytocin infusion, 40 units in 500 ml at the rate of 125 ml per hour. Carboprost may be given IM. Of course, we have to rule out asthma in these patients. And musoprostol 800 micrograms sublingually can be given. So what is the management of severe PPH?
In severe PPH, the massive obstetric hemorrhage protocol has to be followed. For that is communication, resuscitation, investigations, and definitive treatment. We have to communicate with the senior obstetrician, neonatologist, anesthetist, porter, scriber, blood bank has to be informed. Then in resuscitation, ABCD protocol has to be followed. The patient has to be kept flat, warm environment, and Foley's catheterization, input-output charting, and monitoring of the vitals, respiratory rate, pulse, blood pressure has to be monitored continuously, temperature every 15 minutes. Till the blood arrives, we have to resuscitate the patient with the fluid resuscitation, that is 3.5 liter of the clear fluids, that is 2 liters of crystalloid followed by 1.5 liters of colloids has to be done. And then we have to investigate the patient, complete blood count, coagulation profile, RFT, LFT, and grouping saving has to be done. And then we have to, if the blood, then we have to go for the, if it is atonic PPH, we have to go for uterotonics sequentially. And then that is oxytocin, and then methergine, ruling out hypertension, carboprost, misoprostol, tranexamic acid, and then the surgical management has to be done.
Yes. So first, we will give 2 liters of isotonic. I think all of this has been explained. If blood is immediately not available of the group and match, then O negative blood can be given, K negative red cells. Administration of FFP guided by hemostatic testing. So I think we just rush on. This is the flow chart which has been already explained. Coming to mechanical methods. How will you do, what are the mechanical methods by which you will manage PPH? Suppose
Yeah,
all the
by
medical
manual
management has
compression,
not.
you try and massage, balloon tamponade, and yeah, Bakri balloon, and external aortic compression, then anti-shock garment, pneumatic anti-shock garment. PPH cannula will also help in some cases. If it is on cesarean table, then various devascularization. Oh, that will be in surgical. Yes, yes.
So this is one video I would like
But
to share.
intrauterine packing is not advised nowadays.
Actually, after using this PPH cannula, I'll just demonstrate. This is a patient who was having atonic PPH, and even after all the oxytocics were given, the bleeding was still occurring. I was giving massage, but even after all the uterotonics, bleeding had not stopped. And this is the PPH cannula, which actually I'm very fond of because it is so effective. In this patient, you can see that after I've applied this PPH cannula, there is no bleeding. The bleeding has miraculously stopped, and this has gripped the uterus. So when you try to tug it, I'll show you again. When you try to tug it, it will not come off. You can see that the bleeding has stopped. Can you see? This is the same patient previously who was having bleeding. So this is a very important tool in cases of atonic PPH. So coming to surgical methods of managing PPH.
Compression sutures, Bleibelin sutures, Kocho sutures, serial uterine artery devascularization, uterine artery ligation, ovarian artery ligation, internal linear cartilagation, uterine artery embolization.
In places where this is available, embolization. Otherwise,
by radiologist.
sometimes we have to resort to hysterectomy also in severe cases.
Yeah, end is hysterectomy.
So secondary PPH management, because it is due to most commonly endometritis, then antibiotics have to be given, and if there is retained product, then we have to explore. But the thing is that it has to be done by the most senior obstetrician because the uterus is very soft and there might be chances of uterine rupture, perforation. So as I was talking, medical legal aspect during antepartum period, patients and attendants should be explained during antepartum period itself. that labor is unpredictable and adverse events are possible. Patient and attendants should be informed about events as they are happening as far as applicable. Proper documentation, including date, time, methods to control bleeding should be there, and various charts, if they are available, can be used. So thank you all the panelists for your...
Thank you, Prachi.
Thank you. Thank you for all the good answers. And I thank Archana Madam again.
Thank you.
Thank you everyone for giving us this opportunity to learn about new topics and old topics as well.
Yes, Viva Madam has read everything and now all the questions out before the exam. Everything she has read, she has covered everything in detail. We can make out. And Dr. Prachi, that was an excellent presentation, and within a short while you have covered almost everything of the topics. So yeah, including the latest advances, the medico-legal aspects and everything. So that was, and we had such great panelists, so enthusiastic. Now we have Dr. Poonam Dikshit for her talk, and I would request our chairpersons for the session to introduce her and say a few words.
Can I start sharing my PPT?
Yeah, please, please.
Can you, is my slide visible? Hello?
Yes, ma'am. Yes, it is visible.
Yeah, visible.
Okay. So apologize for delay, but then I was listening to the panel, which was very good. Congratulations, Susmita, Prachi, and all the panelists. Obstetric emergencies are always, there is something to learn. So my topic given to me was, is instrumental delivery becoming a forgotten art? So just trying to change how to go on the next. Should I just a sec.
You
Yes.
convert it into slideshow.
Yes. So there is a changing pattern. There is a shift the way people are practicing. Historically, instrumental delivery was a very important way to deliver the babies, and even mid cavity, when we were training, even the mid cavity forceps was done. Over recent decades, a significant rise in cesarean section has happened all over the world, and this shift raises the question, should we evaluate the utilization of instrumental vaginal delivery in current obstetric practice? We use either forceps or vacuum extractor, and worldwide 10 to 20% of laboring women need obstetric intervention in assistance, and instruments, either ventures or forceps, they compromise about 6 to 12% of total interventions. So it is a very, I think it is an invaluable tool for the obstetrician, and this also is going to help us what is the Millennium Development Goal 5 in reducing maternal mortality and morbidity. My major focus concern is, when we do a proper instrumental delivery, we are able to reduce the incidence of second stage cesarean sections. So why is it decreasing? Because people are losing skills. I'll just share a survey very shortly, which I did in my group, and about nearly 50 people responded. And medico-legal risk and the training hours, lack of senior supervision, and very easy availability of cesarean section. So let me share the part of the survey which I did. So what did most of them are obstetrician which are practicing. So how frequently they do. So you look at the orange one. So occasionally, only 1 to 3 times a month. And what are the primary reasons for which you do? So Majority, about 32%, are still doing for prolonged second stage of labor. Next is the maternal exhaustion, which is 58.7%. And then you have the cardiac diseases and fetal distress, that is 43%. So what are the primary factors that might deter you from attempting an instrumental labor? That was my one question. So lack of confidence, about 24%. Concern, that is, you just notice the 73% said that they are worried that the fetus might get injured. In our clinical practice, what we do is strict monitoring is very important. So we monitor the fetus by continuous CTG. So, and if we do instrumental in a proper way, then we can avoid injury to the fetus. Then concern about the potential maternal thing, that is also 48%. Availability of immediate cesarean, about 31%. Limited training opportunity. So because the seniors are not doing, so the junior colleagues are also not learning. And then there are certain institutional policies. So do you agree? And about 60% said that yes, they agree that it is a forgotten art. And talking about the training, just look at the big red thing. The training of the residents is inadequate. That is what most of the responders said. And do you believe there is a need? Yes, because this is a positive sign that 91% are saying that there is a need to train. So why we need to improve? Because it causes enhanced and standardized residency training program with dedicated IVD components. We need mentorship programs. And the medical legal issues which was discussed in the previous panel, that also worries people. So as long as we take care of it, if we are doing the fetal monitoring, we are documenting, and we are consenting properly, and we are doing a proper assessment before we proceed to the delivery. And the other thing which we can do is training on simulators, like where is the flexion point, and there are many training courses, like in UK they have the MOET, where they train people on instrumental delivery. So I'm a strong proponent of instrumental delivery. What's happening in, I would like to share a story long back. It's a very old story, but scenario has not changed. A woman was rushed to my place in the middle of the night from a remote place. She took nearly 2 hours to travel, and she was really screaming. When we did the CTG, the head was in the transverse position, about +1 addition, some molding edema. She was a primigravida. She had run away because she wanted a normal delivery. What we did is we took her to OT, gave her a spinal anesthesia. With good analgesia, the head came down, and we were able to do a rotational ventouse. I personally use Kiwi Cup, which is a very great instrument to be used. As long as we apply on the correct point, it works wonders. It is like something like, like a magic. It starts rotating the head, provided there is no cephalopelvic disproportion. So just to say, we have to use the right instrument. The person using it has to be trained. Then we need to assess the fetal position, the station. During normal labor also, all the residents and trainees, they should be encouraged to feel for the fontanelle. If in doubt, ears can be felt to assess whether it is OP or OA. And again, doing a bimanual, ballatability, to see if during contraction, the head is descending very nicely in pelvis. That is a very good clinical sign that there is no CPD, and we will be able to deliver the fetus safely. As I said, fetal and maternal monitoring, you noticed in our response, majority are worried about the injury to the fetus. So a continuous CTG, or if CTG is not available, we will do intermittent auscultation. Mother's condition has to be monitored, her blood pressure, pulse, temperature, and everything. Very important point is the adequate analgesia. epidural, which we use in our clinical practice, but not available everywhere. So we can give a good pudendal block to achieve a good instrumental delivery. And last, which is most important, a consent has to be taken. What if the lady herself says that she does not want to go through, or the family says? But I don't know what's happening elsewhere in India. We have people from Madhya Pradesh and all over Bihar. Right now, where I'm working, that is Patna, there is an intense desire for a normal delivery. And during second stage, deflexed OP head, in that the kiwi really comes as a boon. My topic was I'm already late and everybody's in the end, so I'm just coming to I'm coming to the last few slides. This is one thing which I really want to show. This is the kiwi cup I use, and very easy to slip. Earlier, I was using metallic cups for OP positions, but this one gently, you just you put it on your palm and you can gently glide over. And what is important is the flexion point. So we feel for the bregma, midline suture, the bregma. And in labor, one important clinical clue is to distinguish between posterior and anterior fontanelle. There will be 4 sutures going from the anterior fontanelle, whereas from the posterior fontanelle, only 3 sutures are traveling away from the fontanelle, and posterior fontanelle is a little smaller than the anterior fontanelle. But in the intensity of labor, when the woman is screaming, there is caput, there is molding, these things do require a certain degree of clinical skill so that your cup goes in the right place. So 3 centimeters before the bregma, if we put, so like a fulcrum, it flexes. So, and this point is called flexion point. This is one key message which I want to give that is very important to the ventus. I'm personally more in favor of ventus delivery, because with kiwi we get a very good suction. It is not a machine where your pressure fails and you can't do that. But of course, in a very good OA position, a forceps can also be used. So we all agree that it is declining, but we also agree that it plays a very crucial role in proper management of labor. And no unit can say that we do not do instrumental delivery. So I think a lot of you must have heard of Odon. I went to this RCOG World Congress in Muscat, and they had one room dedicated to the Odon. One of the hospitals in UK, they are doing a trial. I think the results will be coming out soon. So the Odon is a device which sort of, I think it will allay the fear of people who will say that we don't know where to apply the cup and what to do. Basically, this is the story itself is very fascinating. The concept itself was developed by a car mechanic named Jorge Odon in Argentina, and way back in 2006. And based on his principles, and then they did something in Argentina, and I think way back in 2007 WHO also endorsed it. So currently under trial in all countries. When I was in Muscat in the RCOG World Congress, there was a coordinator from India itself. So very soon it will be available in the market. I was looking at the price and they said it is $50, which is not much considering what we are going to achieve. So what, although you can watch, there are a lot of videos there. So basically there is a cuff which you just apply all around the baby's head, and then you put pressure, and with gently we can deliver so there is no stress of applying it in one particular part of the head, that is the flexion point. But until that comes, I think even using kiwi cup on a flexion point is not a very difficult task, and we should try to. I was talking to people in big medical colleges, they also use it. Right now the kiwi cup itself costs something like 4,000 in India. So coming to the end of my talk, I would like to conclude. One sec, I just want to move. It's not moving.
Hello.
Hello, yes, just last 2 slides, it's not moving. I'll just,
Okay.
okay. So finally, to conclude, the instrumental vaginal delivery remains a relevant and potentially life-saving skills in modern obstetrics. There is a perceived risk of declining expertise due to various factors, medical, legal, and the risk to the anticipated risk to the fetus is the most. Proactive measures are needed to ensure adequate training, maintain competence, and promote appropriate utilization of instrumental vaginal delivery. And hopefully, when Odon is available, people will no longer fear and will be able to do more of it. So thank you very much for giving me this opportunity. And once again, I apologize for the delay. Thanks, Dr. Archana Basair, for giving. She called long back to give me to talk about this topic, which is very close to my heart. I really love this technique and it's a skill, and I do use it quite a lot to achieve proper, in cases of persistent OP, deep transverse arrest. So thank you very much, everybody, for proper listening.
Thank you, Poonam. It was really a nice hearing. Odeon really something we are looking forward to if it comes.
Very good evening to everybody. Thank you, Poonam, for that wonderful and brief talk. Actually, you really said that now people are not having training in the instrumental delivery. The PGs and the recent residents may not even have seen them being used, like killings we used to use and see. But now everyone should know that there are particular indications for instrumental delivery. Like they were just talking about cord prolapse in the panel discussion, and when there is a severe bradycardia, full dilatation. So the criterias and complications of each instrument should be known. And of course, Odon, as you mentioned, I think it will be really recently available now in future. And that will be a good one instrument where there'll be very few complications, like we fear in forceps application, that if you apply more pressure, there could be, or it is malapplied, there could be intracranial hemorrhage and vaginal tears. So all that, those complications will not be there with it, and it will be a good instrument. And like we update ourselves about recent things, you have updated us about what we had learned in the past, and everyone should know it. Also, we should know when to stop using it, how many pulls to give, and all that. Thank you so much, Poonam, for that excellent talk.
Thank you, ma'am, and you introduced and then you waited for me.
Actually, you must have got stuck in some
Thank you,
emergency, I'm sure.
Kumudni.
Yeah,
Thank
good
you, Poonam
evening.
Di.
Thank you.
Thank you, Poonam madam, Kumudni madam, Dr.
Thank you so much. It was a very nice one. Very nice one.
Archana madam and Dr. Sushmita madam. It was very nice and very informative session. I think all of us, we have brushed our
Obstetrics.
All the important obstetrics topics.
Thank you. Thank you
So
so much.
We are at the end of the session, and I think nobody is willing to go away. Actually, it is very nostalgic now. It is very nostalgic for me to meet all Bihar people. My second home.
You have to come here again.
Yes, I will. Yes.
Archana madam will also have to come, and Brajbala.
Yes. I'm coming.
Prachi,
It's been long due,
active.
Prachi. I have to come.
Yes, you are welcome here at Muzaffarpur. We are welcoming you.
Yes, I will be coming. I will be coming soon.
And the kind of enthusiasm, the kind of affection, love, everything you people have shown, we are extremely grateful. And I think we had a very nice session, and we have brushed up our obstetrics knowledge to some extent, got to learn so many things. Newer ones, the Kiwi Cup is definitely encouraging. And I would request Basair ma'am to say one or two words and then we conclude. My sincere thanks to everyone, all the faculties, to Pharmed who have helped in and out throughout. And special thanks to Dr. Prachi. So much.
most welcome मैडम, आपसे भेंट हो गई, बहुत अच्छा हुआ, आपसे मुलाकात हुई. You belong to this
next time से कुछ नहीं बोलने का.
Thank you so much.
Thank you,
Thank
Sushmita,
you.
for moderating such a beautifully panel. And I think connecting with everybody. So I really, from my bottom of my heart, I would like to pay thanks to each and everyone who have really joined in, all the faculty members, my dear friend Poonam, in spite of some tough task in the operation theater, she rushed to join in and keep her promise of delivering a talk which we all were waiting, and moderating a beautiful panel, Prachi and Sushmita.
She had to come. The baby was waiting for delivery, so we were just waiting that you would come and deliver with some instrument. That is what was going on.
That's right. So thanks, Braj. Thank you, Dr. Sunita, and thank you all our master of ceremony, all the chairpersons, all guest of honor, chief guest, and all the moderators and experts. And my special thank to Format, especially Sudeep ji, who has been bearing with us when we change the photographs and we change, or like so many things go into making a flyer. So he's very patient, and he keeps making the changes. So thank you. I'm looking forward to connect with you all again, and look forward to see you in person soon.
Thank you.
Thank you, everyone. And we wish to invite all on in September. We are hosting embryology conference in Indore. So we invite all of you, if you can join, please. Thank you so much for
And
joining.
we will take this opportunity to ask all of you to plant some trees on 5th of June. We are having this environmental day, and this is very important that we plant trees and we look after the trees. And Muzaffarpur Obs and Gynec Society will be planting trees also, and we've already chosen all the place and we've made everything ready. So 5th of June, remember.
Thank you so much, Prachi and Dr. Vibha ma'am, for putting all the efforts. And I request all the Bihar OBGY Society, Patna, Muzaffarpur, Bhagalpur, Sitamarhi, and Saharsa, Gaya, everyone, please do this plantation activity for this, our Mother Earth, for our planet, and for health of our women, because environment is playing a lot of effect in all the diseases, in all the reproductive outcome. So I request all of you to please put your efforts. Thank you so much.
I'm sure, Brajbala, your dream will come true. More than 1 lakh trees will be planted on that day.
Yes, madam, and I hope they will survive. That is the most important thing. That's why we're putting a lot of efforts, and everyone is doing so enthusiastic work for that. That's amazing.
Thank you, and bye for now.
Thank you, and bye bye everybody. Bye Archana.
Bye Poonam.
Bye. Pranam Poonam di. Bye bye.
Bye bye. बहुत अच्छा था.
हम अपने बेटा को बता देंगे कि उसका पढ़ाई हो रहा था. बहुत खुश होगा. वही बनाया था ना वो एनिमेटेड